Hi, my name is Demetris Kaoli. I'm a medical physicist. And today's presentation is about dosimetry-radiation safety and regulatory aspects. Is anybody of you working on a department that you do patient-specific dosimetry for radionuclide treatment therapies? You do? You do patient-specific for every patient, for every therapy? Okay. We don't. Intuitively, we know that is not right. But dosimetry is, as shown in the image, sometimes is complex. The image shows a device that dosimetry is like that no dosimetry is like one switch, where dosimetry is like a number of switches and buttons that represent the parameters that you have to have in mind in order to do dosimetry. What people think is that as long as a simpler empirical method provides safe and effective treatment, they should be considered as preferable. And also that claims for specific dosimetry methods have to demonstrate that a frequency of excess toxicity and or underdosing is lower. Still, even if we have in mind that there is the option of dosimetry, most of the departments still don't do dosimetry, and they administrate fixed doses. And this is a number of exams of therapies that you can administrate fixed doses. Some thoughts is that if treatment efficacy is dependent on absorbed doses, as the case for the radiotherapy, a huge range of treatments are currently being administered. We have to limit toxicity, so if activity administered to all patients is governed by toxicity, to the most vulnerable patients, many patients are undertreated. And individualized treatment planning will deliver higher doses to most patients without risking toxicity. Now, is dosimetry mandatory? As of Euratom, that says for all medical exposure of patients for radiotherapeutic purposes, exposures of target volumes should be individually planned and their delivery appropriately verified, taking into account that doses to non-target volumes and tissues should be as low as reasonable, achievable, and consistent with the intended radiotherapeutic purpose of exposure. Here it doesn't say clearly that it is, but below it explains what therapeutic means, and therapeutic means pertaining to radiotherapy, including nuclear medicine for therapeutic purposes. So it is mandatory, even if most of us don't do it, according to Euratom. How is dosimetry possible for nuclear medicine studies? There is no straight answer. You can do dosimetry on anything. It's just a question of how much work is involved and what accuracy is aimed for. Dosimetry is a calculation of the total absorbed dose to individual organs or the whole body from intended radiation exposure. Dosimetry information is supplied with all radiopharmaceuticals as shown. Here is a leaflet from a radiopharmaceutical that gives you information on how to do dosimetry. And I once was in a training at IAEA, and our teachers there, some of them that were really working on dosimetry, told us that there are some values on leaflets that they don't actually know where were calculated or if they are right. So I don't know if we can use this for dosimetry. Also, this is not patient-specific dosimetry. This is dosimetry for groups. Then there is the Myrt equation to do patient-specific dosimetry. And the dose is delivered, where it says that the dose is delivered to an organ, is equal to the total cumulated activity within the organ times S, where S is a correction factor based on characteristics of the administered radionuclide. So the Myrt equation is that the dose is the accumulated activity multiplied by the S factor. In order to calculate these values, you have to have in mind some other values, like the physical, the biological, and the effective half-life. The calculation of dosimetry relies on an understanding of the different types of half-lives used to describe the radiopharmaceuticals. For example, the physical half-life, as we all know, is the time it takes for half of the nuclide atoms to become stable. The biological half-life has nothing to do with the radioactivity, but it rather reflects the half-time for exertion of the material from the organ or the whole body. For instance, the biological half-life of technetium-99 NDP is the time it takes for one half of the radiopharmaceutical to be filtered and excreted by the kidneys and bladder. The biological half-life of a radiopharmaceutical is not affected by the physical half-life of the nuclide. That means if we use the same radiopharmaceutical with different nuclides, the biological half-life will not change. The effective half-life is a measurement that combines the above values. It is the time required for one half of the initial radioactivity to disappear from an organ or the body, both by excision and physical decay. The effective half-life is always shorter than either the physical or biological half-life and is calculated using the formula 1 divided by effective half-life equals to 1 divided by biological half-life plus 1 divided by physical half-life. Here are some examples of biological and physical and effective half-life. For example, for iodine 131, for 30% uptake, the physical half-life is, as we all know, 8 days. The biological half-life is 70 days. And thus the effective half-life from the equation is 7 days. So 7 days is the time we needed for an organ for the activity of an organ to be reduced to half, or whole body. I'm showing these values because we have to show them in order to do an example of dosimetry. The time activity curve is that where the initial activity is the amount of the injected activity that is in the organ immediately after injection. And the time activity curve can give us the activity within the organ as a function of time. The cumulated activity that is needed for the Myrt equation in order to calculate, in order to do dosimetry, is the sum total activity within the organ over the entire time of the radioactivity and that remains within the organ. The cumulative activity can be calculated from the initial activity and the effective half-life of the radiopharmaceutical. The cumulative activity is the first equation, that is 1.44 multiplied by the effective half-life, multiplied by the initial activity. And the residence time, which is also needed, is the time over which the organ will receive the same total dose from the amount of the initial activity, where these two remain constant and then fall instantly to 0. So is this time here? The S value, which is the other half of the equation, I will explain what it is now. The radiation dose to any organ depends on the amount of the activity accumulated to that organ, on the size, shape, density of the organ, and on the energy and type of the radiation it contains. We have already discussed how cumulative activity can be calculated, but the calculation for the remaining factors is too complicated to pursue here. Fortunately, these calculations have been performed for most of the organs of the body, and for the range of photons and particle energies emitted by the medically important radionuclides. These combined factors are referred to as the S value, which is available in standard tables. So all these values are available to us. They've been calculated by others, and we can use them in order to do dosimetry. There is also the term self-dose is used to describe radiation dose to an organ from the radiation within it. For example, the dose to the liver from the accumulation of technetium-99 sulfur colloid within the liver. I'm telling you this because when you're doing dosimetry, you get one dose that comes from the organ itself, and some other dose that comes from an organ near the first organ. So the self-dose is the first example, and there is an S value for all the combinations. For example, you get an S value from dose to lungs from thyroid, and a different S value from dose to kidney from thyroid. You have to do all these calculations in order to get the whole body dose, or the total organ dose from the other organs. This is a simple example in order to understand how dosimetry is done. A hypothetical case of iodine-131 sodium iodine ingestion within the lung as the target organ and the thyroid as the source organ. To simplify the calculation, we assume that the thyroidal uptake of iodine-131 sodium iodine is instantaneous, and that the 24-hour radioiodine uptake is 30%. The ingested dose is 37 megabecquerels, and so the initial activity of the thyroid is 37 megabecquerel multiplied by 30% equals 12.3 megabecquerel. The residence time is the equation we showed before, that it is 1.44 multiplied by effective half-life, and that gives us the 10 days. The 10 days is the residence time. The accumulated activity that comes from the other equation we showed before is 72 millicurie by hour. And now, in order to calculate the dose of the organ, we will use the S value that we can find it in the MIRT pamphlet number 11 for source thyroid and target lung, and is calculated as the value shown in the presentation. So if you multiply the accumulated activity by the S value from the MIRT tables, you get the absorbed dose to the lungs, which is 0.0021 gray. But what we showed again is not a patient-specific dosimetry. Because every patient is different, we need to calculate the activity and the effective half-life of every patient. And in order to do this, we can do it with the gamma camera. But the gamma camera was not meant to measure activity. So what we say, in order to do dosimetry, we have to have a dosimetry calibrated gamma camera. And what we need to calibrate on the gamma camera is the photon attenuation in patient body, the background of the overlapping structures, the scatter, the self-absorption of source object, the partial volume effect for small object, and the dead time count losses. I will not explain all of this calibration. I will just show some of them in order to understand sometimes how complex the calibration of the gamma camera can get in order to have accuracy on your dosimetry. So the attenuation correction can be done either by ACT or by a flat source as shown in the images. You can see that the images, the transmission images from a flat source is not as good as the ACT images. So if you want to have a good attenuation correction image to correct the emission images, you have to use ACT. Also, this brings you in mind that the positioning of the patient is also important. Here are some attenuation correction factors to have in mind, the different. For example, the liver attenuation correction factor is the square root of 7.1, and the lung attenuation correction factor is the square root of 3.3. So it's important. Also, the scatter correction is important because we don't need to get any additional activity in our images from the neighbor organs. In order to do that, you have to do strict scatter correction. Some gamma cameras, what is recommended is that you do at least 2-window or 3-window scatter correction. Some gamma cameras don't even have this ability. The image below, the next, shows how the images changes with scatter correction. So how more clear and accurate are your emission images that you will use for dosimetry. Also, the dead time is really important. There is a note below that says that dose difference with and without dead time correction is 3 times. So if you don't have this, or if you don't do all these calibrations, you can get wrong results on your dosimetry. Here is a summary of how you actually do the dosimetry. Is that you have to do all the calibrations we mentioned before. You administrate the dose to the patient, and then you have to get the planar images, anterior and posterior, for different times. For example, at 1 hour, 4 hours, 24 hours, and 96 hours. This means 4 additional scans for every patient. We calculate the geometric mean of the anterior and posterior images. We correct the geometric mean with the transmission scan that can be either a flat source or a CT scan. We have to draw the ROIs on organs and use software to calculate the organ dose. I say use software and not tables because the softwares, they include the tables, so it make your work easier. And you can find a really not expensive software in order to do this. One of these software is Olinda, that I think everybody knows it. It was the new version of Myrtos. All this makes us think that dosimetry costs additional because we have to do 4 additional scans for every patient. We have to give additional dose to the patient. We need additional personnel to do this, additional software, and additional hardware if we think and equipment, if we have in mind that it's better to use a CT scan for the attenuation correction. And who does the work? In the trainings I've been, it is not clear. Some they say is a physicist, other is a nuclear medicine doctor, and there are other departments that they have dosimetrists, that this is their full-time job. So if you want somebody for a full-time job to do this work, it means it will cost additional. So dosimetry is not only a LICA requirement, it's useful as it may impact patient management. It is feasible, and if you have the equipment, then you just have to use it. It's not that expensive. And if you are trained, it's not that difficult, but it needs in more departments additional training and work. The last subject of the presentation is the dosimetry of the personnel. So we all have our TLD and for whole body monitoring, and for extremity, those who work with radiopharmaceuticals, they can use ring badge as well. But what about the intake? The intake means the total activity of the radionuclide entering the body from the external environment. And doses from intake of radionuclides cannot be measured, but must be assessed for monitoring. In order to do this, you need additional equipment, which can be a thyroid uptake system, like the one showed. And then again, you have to do calibration. In order to do calibration, you first perform on the system a constancy check with cesium and linearity check with europium. And then you have to measure the efficiency with the use of thyroid phantom. What you actually do, you put a known dose in the thyroid phantom, and the system is calibrated. So in order to convert the measurement from the personnel to dose. The measurement, what you do to measure is that you have to perform a background check, because the dose you get from the personnel is really low, so you have to subtract all the background. You position the member of the personnel at the same distance of the calibration phantom, and then you measure the intake in microcurie. Again, there are tables that they convert the activity from inhalation or ingestion to dose. And our experience is that when we try to do this, is that we measured weekly the personnel for 6 months. The results showed that the higher internal dose was below 50 microsievert per year, where the most of the personnel was less than 10 microsievert per year. So exposure to technologies from preparing and administering therapeutic iodine-131 is really, really low, and that makes you think that if it's needed actually to do bioassay on personnel. This is all I wanted to say. Thank you, and if you have any questions.